Our next speaker will be poster number 5, Paraesophageal Hernia Repair in the Obese, being presented by J Wille.
Again, if you have questions but don't want to come up to the mic, please feel free just to submit them electronically.
All right, this button.
It is.
Okay. First off, I'd like to thank SAGES, our moderators, and all of you who stuck around. My name is J Wille. I'm with the Oregon Clinic in Portland, and I'm here to share the results of our study, Paraesophageal Hernia Repair in the Obese. I have nothing to disclose. Laparoscopic paraesophageal hernia repair is a complex foregut procedure with a notoriously high recurrence rate. Long-term outcomes are varied, with recurrence rates reported between 16 and 54%. In particular, paraesophageal hernia repair has been controversial in obese patient populations with concerns for decreased durability. The studies presented here demonstrate conflicting data and have led to some surgeons denying PEH repair in the obese. Therefore, we designed this study to evaluate the outcomes of primary paraesophageal hernia repair in obese patients. We hypothesized that durability of PEH repair is unaffected by BMI. So, standard demographics, surgical details, and perioperative complications were collected. Patients were only included in the study if they met the inclusion criteria shown here. Recurrence was defined as a minimum 2 centimeter vertical herniation at the hiatus, as demonstrated by an upper GI radiograph or an upper endoscopy. To assess the recurrence rate, we stratified patients in 2 ways. First, we looked for significance in patients with BMI less than 35 versus BMI greater than 35. And then we went ahead and we stratified them one other way, and we looked at patients with BMI less than 30 and then compared them again to that BMI greater than 35 group. Here's our results. In fact, this line right here will be of the most significance. We achieved an average of 34 months follow-up with our 234 patients that were included. The BMI less than 35 group was older and contained a higher proportion of males, but there were no differences in perioperative outcomes or long-term or perioperative complications or long-term outcomes. We found that recurrence and reoperation rates were similar between all BMI groups, 23.4% in patients with BMI greater than 35, 24.1% in patients with BMI under 35. Then when we went ahead and stratified to the BMI less than 30 group, we found a similar rate at 23.5%. So in conclusion, long-term recurrence rates for laparoscopic paraesophageal hernia repair are high. Recurrence rates are not adversely affected by weight. Thus, concerns about durability should not be a reason to deny these patients paraesophageal hernia repair. Thank you.
Take a question from the audience, and I have questions.
John Lynn, Chicago again. Really nice study. Your numbers may not have allowed you to do this, but did you break patients into a different BMI range, say something higher? If you set the BMI cutoff at greater than 45 or super obese greater than 50, did it show a difference at all?
We didn't have the numbers to necessarily power that kind of analysis. We had a few patients up in that range, and I can recall at least 2 or 3 that had a recurrence, but we couldn't really get the full analysis on that. So.
Hi, Juan Pablo again. Very nice study. Do you actually offer them something different for like a bariatric procedure to those patients who are over 35? Or it was just the the hernia repair?
That definitely had piqued our curiosity to look at this. In fact, these patients had elected for these surgeries. We had no emergent presentations or anything like that, so it was essentially a decision that they'd come to themselves. One of the surgeons in our office does a good number of bariatric operations and usually presents that to the patient. But in this case, it was just a hiatus hernia or a paraesophageal hernia repair. So.
Thank you.
So believe it or not, we actually talked about your abstract in the complex foregut session yesterday because someone said there's somebody coming out showing that BMI should not be an exclusion criteria for paraesophageal hernia. That was met with a lot of controversy, as you can imagine. And really, that was the question that we have is, maybe it's not fixing the paraesophageal hernia it is, but I would caution you, with an N of 27 or 35 to be promoting this. And also, challenge you to think about doing a study looking at whether or not doing a bypass or a sleeve are both okay, and kind of where to go from there.
I think leaving those options is valuable, absolutely. I think our data is very congruent with the paper just put out in JAMA by Ann Leiter. It's consistent with those results as well.
Nice job, Aaron. I just want to help field that question a little bit as one of the co-authors. But what was happening in our town and all around the nation is patients were being denied hernia repairs for symptomatic paraesophageal hernias because of their weight. And doctors were telling them, you can get a bypass. I'll do it as part of a bypass, or I'll do it as part of a sleeve. But I'm not going to do it by itself because the recurrence rate is not worth my time. And patients were being denied. And we didn't know, we looked in the literature, we wanted to know, is that if the patient doesn't want a bariatric procedure, shouldn't we help them out? I mean, and so that's why we decided to look at our own data to see if that's a reasonable option. We definitely offer bariatric procedures as concurrent repair for the paraesophageals in the obese, but if they don't want it, that's what this paper was trying to look at.
Yeah, I think it's great, because I
Nice
agree with
job.
you. We deny way too many people, and I think that this literature is awesome, so. We've got another question.
One more?
Yes, very good paper. You said standard mesh technique. Could you describe what that was? And do you think that that's why you have equivalent rates compared to a lot of centers who never use mesh?
So as far as the technique goes, I'd have to defer specifically to the surgeons performing that operation, but biologic mesh reinforcement was used in all these patients. It's the practice that is commonly used at our clinic, and we have agreed upon that because it essentially has shown to decrease the short-term recurrence rates.
So what he didn't show, the technique that we use is an incorporated piece of biomesh, either Surgisys or Veritas, depending on which hospital we're at, and we use horizontal mattress sutures with pledgets. That's our standard technique, and it's been that way for about 8 years. We are looking at that overall, if that's making an impact, but the interesting thing that we didn't have time to show in this, but it'll be in the paper, is that we have a Kaplan-Meier curve for recurrences in this group of patients, and it's showing the exact same data as Oschlager's. I mean, it's at recurrence at 3 years is about 30%, and at 5 years it's 50. So we're going to be questioning our technique as well.
Thank you.
Thank you.
Thank you so much. That's great work.